But welcome to this seminar series. My name is Helen Freeman. I'm the Network Coordinator for the Breathing City Network, or the Future Urban Ventilation Network is another name. We're funded by the UKRI and NERC. And you'll see that at the bottom here, we've got our Twitter handle, our website, and our email address for anyone who would like to find out a bit more. Before I introduce Jim, who will be speaking today as our first speaker in the seminar series, I thought I'd introduce a little bit the Breathing City Network itself. So we are 16 academics and health professionals, and our aim is to develop a technical framework for a new integrated health evidence approach to urban building design. And we'll do that by considering coupled indoor and outdoor airflows and their impact on thermal comfort, on noise, and on energy use, and a whole host of other parameters associated with buildings and the urban environment. And our main aim is to bring together researchers and practitioners and policymakers, hopefully like all of you guys out there. And this will help us understand the technical and practical challenges associated with this and develop a programme of research and impact activities that will make this a reality. That's a very brief introduction. If you want to find out more, then we have our website that's on the holding slide. But I'll now introduce Jim. So Jim's one of the investigators in our team. Jim Stewart Evans is a principal environmental public health scientist at Public Health England. And today he'll be speaking about characterising the environmental hazards to health from both indoor and outdoor exposures to air. So I'll hand over to Jim now and I'll mute myself. If you like, oh, there's some holding slides that I had. If you can zip over, Jim, to the next slide. There's just one for housekeeping. So if you have any questions, please enter them in the chat channel and then I can chair them at the end of this session. Please keep yourself on mute. I think everyone is, so that's fine. If you can respect each other's contributions and questions, that'd be much appreciated. And the final thing is that today's event is being recorded and we'll make this available on Twitter and our YouTube channel at the end of today. So yeah, over to you, Jim. Thanks for joining us today.
Thanks, Helen. And chip in quickly if you can't hear me. Hopefully this is working, having tested it before.
That's fine.
Brilliant, thanks. So you mentioned a bit about the Breathing City network. Catherine Oakes is the PI and the rest of the group is on there. And it's Public Health England that I work for, and specifically within Public Health England, the Environmental Hazards and Emergencies Department. So I've got perhaps, I guess, an unusual view of indoor and outdoor environments that's partly framed in some of the operational work that we do around emergency response and around day-to-day exposures to chemicals and indoor and outdoor hazards, such as air pollution and also naturally occurring hazards as well, part of which we cover. So today, really, my talk is summing up a few things. It's some perspectives from that maybe slightly niche world that I inhabit of environmental hazards and emergencies within Public Health England, and trying to translate that into the work of this Breathing City network, where we're trying to look at indoor and outdoor exposures and the balance between the two and the connection between those exposures and health effects. So what I'd like to do is to try and illustrate some of our day-to-day work in the department, some case studies, the types of things that we get asked on our duty desk, out of hours on call, the sorts of emergencies that come in and the day-to-day queries, and lead to a kind of narrative, I suppose, or more a sort of discussion piece on accounting for a range of determinants of health in indoor environments and how to balance some of the conflicts and some of the different determinants of health, and some thinking that we've done in the network about potentially using systems approaches to this, and a bit at the end about framing issue and the way that we might approach this in our conversations and how we present evaluations and interventions. And by interventions, I kind of come from the perspective of that meaning things we can do to improve people's health, actions that we can take to reduce exposures or to improve health more generally. So this is my kind of worldview, if you like, partly framed through emergency response. But if I had to boil down what our duty scientists do and what I do if I'm on call or on duty for us in a nutshell, there's three main elements. The exposure assessment is often based as much on information from the caller and from people who have a first-hand view of what's going on, whether that's fire services or members of the public, the Environment Agency, or so on, as it is by quantitative information. So maybe air quality monitoring or model outputs, which for some types of incident we receive from the Met Office. The other element is risk assessment. So we use that information that we have gathered from the scene, monitoring and modelling outputs to assess people's exposures, essentially trying to determine whether those exposures are acceptable or not and what the consequences of them may be. And that often involves comparison to standards, and the standards that are used really depend on the period of exposure that's of interest. In emergencies, there's a whole different set of health standards that are used compared to what might be used in terms of ambient air pollution over annual averages and so on. So it's matching the two things up. And then what do you do with that information? There's an element that's around public messages, and there's an element around managing risks, so the interventions that I mentioned earlier. So when I talk about some of the case studies that come up in the following slides, that it's with that kind of function of Public Health England, these kind of jobs that we do, if you like, within our day-to-day work. So I represent the bit at the bottom on chemical incidents and fires. We've also got teams that deal with radiological emergencies specifically. I think one of the future speakers in this webinar series hopefully will be a colleague that deals with radiological incidents and can talk a bit more about their work on indoor and outdoor exposures. And we have a team dealing with natural hazards, so hot and cold weather, floods, and so on. So hopefully you'll get some perspectives from them further on in the series. So I've been thinking about how I can categorize some of these issues that we deal with in a way that kind of puts the indoor and outdoor parts into context. And I could approach this in a really kind of black and white way, I suppose, in terms of differentiating between the exposure periods and whether the main hazard is indoor and outdoor. So the case studies where there are problems with indoor releases that are essentially emergencies tend to involve accidents or accidents of things going wrong and need to be dealt with fairly quickly. So gas releases, carbon monoxide, whether that's faulty boilers or even things like people bringing barbecues indoors in cold weather, and the fact that combustion is ubiquitous really occurs indoors as well as outdoors. If the space is unventilated, we get quite a lot of calls that come from A&Es or from people directly where there've been problems with carbon monoxide exposures at high levels. Mixing of chemicals is another issue. I've got a picture there in the top right of community swimming pool. It's fairly common that there are incidents that involve mixing of chemicals in plant rooms that are being used to chlorinate the water, leading to a chlorine release in the plant room, and leisure centre being evacuated and ventilated afterwards. Also happens in miniature in domestic situations where people are really trying to get a bathroom or somewhere clean, and they decide the best way to do that might be to mix all of the things they've got under the sink together. And in some cases, you're mixing up acids and bleaches. You might be generating chlorine or chloramines, noxious airborne hazards from that. Mercury is in thermometers. There's guidance on NHS choices and PHE publications on cleaning up these kind of breakages in domestic settings. We get quite a few calls about them, maybe less so since that guidance was published. The bigger issue is when it's a higher quantity of mercury and it's in things like barometers. And there have been cases in houses where it's got under floorboards and it's being vaporized next to heating pipes and so on. So they can often cause quite a lot of concern with callers, not necessarily so significant in terms of levels of toxic exposure. On the other hand, we do get, unfortunately, a fair number of calls that involve deliberate releases of chemicals where people have done it to self-harm, suicide attempts. And by their very nature, the actual build-up in enclosed spaces is premeditated, whether that's in cars or in buildings, where people may use gases such as butane and propane, maybe inert gases, nitrogen, argon, and so on, or again, mixing cleaning products together. Potentially, some of those cases may not be due to inhalation. People may have ingested products that then lead to issues afterwards in terms of emergency responders treating them and moving them from the premises. So that's the kind of acute indoor scenario that we get to our duty desk. Some of the other ones on there I've not mentioned that have been some sort of big issues with go-karting tracks where there's obviously a load of combustion sources in an enclosed space, much bigger volume, but had some mass carbon monoxide poisonings in those settings in the past. And domestically also the many issues with things like the locations of vents in one property and inlets in another. That can be a problem as well, not just with carbon monoxide, but also with nuisance issues. And we get a few queries that relate to wastewater issues where things are tracking up pipes, and sometimes where pipes have been cured with substances that contain things like styrene. They've got very low odor thresholds, and sometimes that's led to problems. So in these cases, it's the indoor hazard really that's dominating, and the period that we're concerned with is quite short in terms of timelines. It's high concentrations over short periods. And the general approach is to try and address the source, ventilate, minimize time spent indoors whilst it's being sorted out. The problem is that often the exposure's often already happened. You tend to be reacting afterwards to something that's being detected by its very nature that led to health effects. So it's harder to avoid in that sense. The other issue that can occur with these is where maybe the risk isn't so immediate or so high, but people may be unable or unwilling to ventilate, and that could be due to the characteristics of the building that they're in, or it could be due to issues outside the building. So maybe it's too cold, it's too much noise, or they're worried about leaving windows open, and then the problem can continue, or a different approach may be needed. So if we extend this really to outdoor emergencies, outdoor studies, where outdoor circumstances where the hazard hasn't been generated by some kind of indoor spill, it's something that's happened outside, often again accidents. These slides are taken from some work in the US where they've been looking at sheltering in buildings next to some of their sites that store toxic chemicals. There's a whole load of publications around community preparedness and sheltering effectiveness in those sort of cases. And what this slide is showing is that if you have an outdoor release, say it's something like ammonia, a bullet of ammonia in the tank, and it opens up, and you've got a plume that travels downwind, you're worried about the people in houses that may be affected. So you have an outside concentration that effectively goes from zero and increases, and at any given point, that plume will eventually pass the property and drop off again. And meanwhile, the concentration indoors is going to rise, and there'll come a point where it's as high and then is higher than the concentration outdoors. And what this slide is showing is that if at that magic point you can ventilate the property, you're going to lower someone's cumulative exposure, because if they stayed indoors throughout the entire time, then potentially their dose could end up being similar to what it was outside. Of course, toxicology comes into this as well, and it's going to be the case. You can see here that the peak concentration that the person's exposed to is lower indoors, and that's where one of the main benefits of sheltering comes from. This figure on the right illustrates a practical problem, which is that there's no one time that's going to be best for everyone to go indoors or to ventilate. So you can see here, if you've got a moving hazard outdoors, some of the properties that have been in the plume, it's already passed, you're going to have higher concentrations because of that fact, whereas some downwind may only just be beginning to be affected. So quite complicated in those sort of cases in terms of public advice if you're trying to tailor it to individuals or be specific. What we often get though is not that kind of worst case scenario where you've got really dreadful chemical release and levels of exposure that may kill people outright, thankfully. We do get a lot of fires. Must be at least 3/4 of the calls we get about emergencies and issues. And they're not necessarily the kind of things that are done in a few hours, like many chemical incidents are. It can go on for days, weeks. Some of them have gone on for years, where we've got deep-seated fires in, it's often in waste. So it could be things like compost, tires, mixed waste. So this sort of scenario, you might have had a big bang and a nice hot fire at the beginning, but what you're left with is something that's smoldering away in the background. They may set up monitoring and maybe using misting to try and keep the smoke down. But if we think about people's exposure, it's more about what is the forecast over 5 days, 7 days, a month or so on. What's happening in terms of the outdoor environment and indoor environment in those cases. And you get really variable levels of particulates and other substances during fires. So here, this is data from the Osiris monitor in a fire over 24 hours. So you can see the outdoor concentrations are spiking as it's affected by smoke. If you apply some assumptions about air change rate to this, you can see that the outdoor concentration is affecting the indoor concentration, but you're not hitting the same highs because of the delays due to air exchange and the fact that outdoors is up and down. And then if you start to account for other factors such as deposition and interactions with attenuation basically, then concentration is lower still. And this is why really often people default to the shelter advice in 99 times out of 100, it's going to be the appropriate thing to do. The problem is where you start getting into these cases where it's going on for months or years, or you start considering things like dioxins, aside from the chemicals that can cause acute effects. So BRE did some work for us in the past on this, and they were using wind tunnel releases of neutral and positively buoyant plumes, and these aren't the actual arrays that they had. I think these are other photos colleagues put in, but they were using blocks that simulated different densities of buildings in urban environments, and they tried to characterize some of the building parameters and add on some of the weather parameters that we get from the Met Office, so that we could produce graphs that are similar to the ones that I showed earlier, that basically show the relative or absolute level of concentrations indoors. In practice, very difficult actually to get the input data to use these. We've often got the weather data. We've more rarely got any concentration data. Sometimes have some information to characterize buildings with, but it's often relative rather than absolute. We're often looking at trends rather than having something to compare to standards. So in these cases, I've talked about chemical incidents and fires. The other things that come up are air pollution episodes. So if you think about maybe summer conditions where we have periods of days or longer where there are high levels of ozone and particulate matter, we tend to get these air pollution episodes, and I suppose you could put them into the same sort of category where you've got this dominant outdoor hazard. It's a relatively short-lived exposure that may go on for some days or weeks. What was I going to say about that? It'll come back to me. But you can also apply this, I think, to some of the hot and cold weather episodes, so if you put it like that, or hot and cold weather events. So for air pollution episodes, there'll essentially be forecast and alert put out, information will be issued that will include health advice. There's a similar sort of process for times when we're going to have a heat wave, or times when the weather's going to be particularly cold. The extreme events team are involved in hot and cold weather plans, and information essentially gets issued and goes out to people about what to do in these environments. So I think you can treat some of these as almost sort of special cases where the way that you'd approach maybe buildings and ventilation and advice might differ from day to day. day-to-day times. But generally, in the short-lived ones, we're advising people to close doors and windows, minimize time they spend in smoky places, and try and ventilate once a hazard has passed. Some of the issues around it are, as some of those slides show, that one-size-fits-all advice isn't always appropriate. And in the real significant chemical incidents and big releases, you really want to be prompt in issuing that advice. And it takes time to do that. It takes time for people to receive it. It takes time for them to act on it. And if you're looking at everything in the round, then building in all of those delays and working out what people are actually doing after advice has been issued versus what's happening is a challenge. And ultimately, in the very long running ones, indoor environments tend towards the outdoor environments as eventually the concentrations, in the absence of anything else, will tend towards each other. So there's a potential issue there. So in terms of longer term stuff, and back to the indoor, we get quite a lot of calls where things may have leaked. At the moment, there's a couple of cases that involve solvents leaking into drainage at industrial sites or in car parks that have then got underneath surrounding houses. So there's a prolonged period of weeks to months and so on where volatile organic compounds are getting into people's buildings because of that. Certainly in more rural communities, people more like to have fuel oil as a supply for heating and so on. That often you end up with fuel oil spills, particularly with older infrastructure that can then track back into houses. It sometimes also lead to problems with water supplies getting into plastic pipes, as well as inhalation of airborne hazards. Carbon monoxide as well. I think the acute effects may be 30, 40 deaths a year, but there's a much bigger numbers in terms of morbidity of people exposed to lower level chronic exposures to carbon monoxide that may be undiagnosed. The symptoms are very non-specific, so similar to things like food poisoning and flu. So that's a particular issue as well. And then more on the ground gas side, and I hope I can get a PhD speaker to pick up on this in one of these seminars in future. Radon, which is naturally occurring radioactive gas. There's a whole program based around working with the BGS to map out areas that geologically may be sources of radon, and look at measurements in properties within those areas that may be affected. And then if there are high radon levels indoors, then to look at installing extraction and so on to reduce people's exposures. So I mentioned that sometimes these can be continuation of those kind of emergency circumstances, or it can start with a kind of release that then becomes a longer term issue. It can involve land pollution, also sort of more day-to-day sort of things, emissions from activities indoors over long periods, so cooking, wood burning, incense, basically anything that's going to emit something as an air-door pollutant indoors is potentially going to lead to chronic exposures. That can include consumer products, furnishings, so things like VOCs coming from carpets and furniture, and so on. The advice here in terms of addressing the source, that the ventilate bit is more for if you kind of detect it and you know it's there and you can respond. The same with alternative accommodation. It's really going to be the more serious cases here. So when you're looking at months and years and emissions from things like cooking indoors and so on, a lot of this is not necessarily going to be maybe recognised by residents or users that there's an ongoing exposure to pollutants or to a hazard. So you've got that recognition of the fact that exposure is occurring is the first problem, and that people may sort of see it as inevitable or be willing to tolerate it. And I mentioned earlier that in some cases also people unable to properly ventilate, unwilling to ventilate, and there may be issues, particularly in some of these spills where it's come from a neighbouring property or somewhere else, about accountability and actual costs of cleanup. Sometimes for those sort of big incidents, you're running into tens, hundreds of thousands of pounds, and depending on where it's come from, it may not be covered by insurance and so on. And then lastly, outdoor exposures. I've put source of air pollution. This comes from PHE Health Matters. I'll drop a link into the chat actually afterwards. looking at sources of outdoor air pollutants. So perhaps surprisingly high is the contribution of the residential sector and wood burning to primary particulate matter. So there's a high health burden associated with particulate matter in outdoor air, which tracks back indoors as well, in terms of PM being a particular problem. But you can see there's a whole range of sources, from road transport, industrial processes, to residential properties themselves, agriculture, and so on. So here, where you've got an outdoor hazard, the sorts of things that we get phoned up about on duty often, again, sort of detected problems, I suppose, if I can put it that way, where you might have something like a chicken farm or a steelworks that's leading to air quality issues, and there's residential areas downwind or nearby. So you might have a kind of smoking gun, if I can put it like that, in terms of nearby emission sources, and it can be related to particular chemicals or pollutants that may be in the emissions profile from a certain industry, or it could be more generally nuisance issues where people are reporting odour or smoke or noise outside, where you've got these kind of recurring outdoor issues, and they can be exacerbated by the types of buildings that people live in as well. So if I apply hot and cold outdoor conditions to this, the building itself can lead to overheating or maybe underheating, maybe issues with ventilation that can act as modifiers, I suppose, to these outdoor hazards coming indoors. So there's an issue here potentially with detection and recognition, when a lot of these things might not be hitting acute thresholds that people maybe notice them or suffer immediate harm from, but are definitely leading to health burdens in the longer term. And again, accountability and costs of remediation, particularly when it comes down to identifying where did that particular source of pollution come from locally, and in terms of reducing people's exposure to it, who pays for it, and how much does it cost? And if you're sort of thinking about heavy industry and some of these things, that the costs can be substantial, and also the exposures can be substantial in a population sense as well. So this all leads me to sort of think about optimization, and you can see people's exposure has a contribution from outdoors, as a contribution from indoors. So what we're really trying to do in terms of protecting health and health improvement. So thinking about this, that in terms of principles, we're trying to avoid crossing red lines, if I put it like that, that we don't want to exceed thresholds that lead to immediate harm to health or deterministic effects on health. So don't want exposures to lead to discomfort, disability, death, and so on. And that kind of thing is featured quite heavily in my presentation, some of these case studies around emergencies. So in the cases where you're not really hitting those kind of thresholds that you would say this is definitely unacceptable, there's another aim here as well, which is minimizing people's exposure in the longer term to non-threshold pollutants. And by that, I mean pollutants that have some level of health effect, irrespective of what the exposure is. So in these cases, you're trying to minimize people's exposure, get it as low as practicable, to reduce the overall burden on public health. But in doing so, those pollutants and exposure to them isn't always the main driver. It might be something else indoors. It might be thermal comfort, it might be noise. People's behavior itself comes into play. And also what people do and don't consider acceptable can change over time as well. So there's a whole load of moving parts if we're trying to think about what an ideal might look like. I think in the way I've categorized this with acute, indoor and outdoor, and chronic, indoor and outdoor, I think maybe we can look at developing rules of thumb for some of those kind of clear-cut circumstances. But in many cases, it's not so clear-cut. You know, an emergency presents you with immediate choices often, and then as you get into the longer term, it becomes more of a grey area. So there's also a need to look at exposures over time and get that resolution to have a more nuanced approach. And I think if we go back to individuals, that people will want to look at their individual circumstances. So can they have an assessment that's based on their particular case? Can they have information that is usable by them? And do they actually have the control to turn that information into action? I think they're all useful things for us to think about in this this work that we're doing with these breathing, the breathing city and other network activities. So I think what's clear is that the whole range of environmental determinants of health all acting at once. It's not just air pollution, we're also thinking about things like relative humidity and heat and noise, that all interacting. Some of them affecting the same health outcomes, maybe having additive effects or modifying effects. And we tend to focus on, I suppose, things that we're concerned with or interested in. So we might be picking particular types of pollutant or types of building or types of people and so on, and narrowing down the focus. I think it's useful to have a kind of bigger picture approach that tries to tie all of this together. So in the network, we've begun developing a system map and trying to bring in outdoor environments and the built environment and behaviour and exposures and health outcomes. And I'll ask Helen if she can drop a link to this in the discussion shortly. You should be able to access it, and I won't dwell on it too much here, but just to say that what we've been trying to do is represent the outdoor environment and the concentrations from that, the indoor environment and sources there, the fact that you have indoor-outdoor exchange and this great balancing act between them. And that's affected by the design of the building and how it's maintained and how it's ventilated, people's behaviour interacting with ventilation, and factors affecting that, behavioural factors affecting that, being driven by some of the things here like heating and cost, which aren't necessarily related to hazards. But as it comes round, you've got a whole range of things people are being exposed to at once. So pollutants, biological hazards, there's the question of noise indoors, whether it's coming from indoor or outdoor sources, and a range of health outcomes that then is affecting people's health and feeding back into demographics of the population, the way they behave, the way they interact with buildings. So we've started developing this really to try and put everything in its place, if you like, and to connect any one area that we're interested with. Does that really lead to people's exposures, and how does that affect health outcomes? And is the particular problem we're looking at important or not in terms of how it affects exposure and how it affects health afterwards? So we'll drop a link into the chat box for that, and people can have a look at it. And I won't dwell on it more here, but hopefully it's something we can look at a bit more during the network work as we go forwards. We started thinking about that, and I think it helps us put some of these things into context in terms of balancing indoor and outdoor sources of pollutants. And within public health, we're always applying this source pathway receptor framework. So we're thinking about who's affected, but where's the pollution coming from? Where's the exposure coming from? How's it getting to people? And who is it that's being affected? What's the effect? Because if we can remove sources or if we can modify pathways, then we're going to reduce people's exposures and improve people's health or protect people's health ultimately. So some of these questions about the built environment and its role and people's behaviour and its role, I think we can start using this kind of approach to bring it all in and consider it as part of this bigger picture. So I think these sorts of approaches are potentially useful because there's no one size fits all really. Everything's connected and everything's changing all the time. I think sometimes we're going to be picking a particular outcome that we're interested in. You've seen from some of the issues that I've presented that some of it can be forced, where you've got a dominant indoor or outdoor hazard that presents an immediate risk, and you can see how immediately the public health interventions and advice sort of shift around, advising people either to shut up shop to prevent an outdoor hazard getting in, or to ventilate to reduce exposure indoors and let the fresh air from outside. But it really depends on the case and what we're looking at, and it's going to be changing. There'll be loops, feedback loops between things. If we think about things like the effects of outdoor noise, maybe disincentivizing people from opening windows and so on. And when we look at evaluations and interventions to improve health or to reduce people's exposure, we're interested in the context and the mechanisms and the outcomes. And I think some of these approaches in terms of categorizing can help with generalization, but really need to approach it in a case-specific way as well for some of these particular problems. And also that applies in terms of thinking about people's dose and toxicology, that we're interested in reducing population level exposures to pollutants, but also when it comes down to it, there's particular scenarios and cases where you are looking at subsets of the population or even in individuals in terms of if you're looking at your own behavior indoors, your own exposures in your own house, you'd be trying to characterize the exposure, how often, what's being produced, how often you're being exposed to different things, your own health status, are you particularly susceptible to any of these exposures, and so on. So there's two angles to it there. And some of the work that we've done in the past is potentially relevant here. The pictures that the graphics I've put on the bottom are for some work that PhD did reviewing the effectiveness of evaluations to improve air quality and health. And we were set a task with this really of reviewing everything in terms of outdoor air pollution and potential actions that could be taken to reduce people's exposure and improve health. The kinds of things that people were interested in and that can be sort of built into these discussions and these network diagrams and so on, the strength of evidence of in the literature and in practice of what works and what doesn't. And also the level of effect is important to consider too. So there may be good evidence that things work, but if they're only leading to small changes in exposure, the benefits in doing them might be quite small. Also, the practicalities become very important as well. So it's not entirely an academic exercise. So how much does it cost? Is it feasible? How long is it going to take to get the benefits? These are all sorts of questions that people want answered before they think about whether they'll actually do it for real. So when we were doing this, we'd carried out reviews in different sectors, those areas I presented earlier, different outdoor sources of air pollution. This is also something I can drop a link to in the chat actually. And it's very difficult really, because to come up with quantitative estimates and comparing maybe, I don't know, a policy around road tax to reduce vehicle emissions with something related to spatial planning and improving active transport and modal shift to cycling and so on. Trying to compare all these things together in the round, you really want very specific details. Well, what does that policy actually look like? What's the spatial area that's affected? But that side, kind of localized side of it, really needs the specifics to look at. And we were trying to generalize it at maybe a national level with this. The way we did it was thinking about whether things had an effect at scale. So would they potentially be effective across the entire country? Could they really reduce exposure on a population level? Also, what was the potential impact locally? So if you think about maybe something like abatement technologies on an industrial process, so you're fitting something to emissions, it's going to be potentially beneficial to the local environment. If you do that at scale across an industry, it's potentially beneficial at a population level as well. And we realized that we had to bring in some other considerations about things like access and quality of green spaces, physical exercise. Some of the interventions here may not have a huge effect on air quality, but there may be convincing reasons to do them on public health grounds because of benefits associated with physical exercise and so on. So it was important for us to represent that and to represent potential exacerbations of health inequalities or interventions that could address health inequalities. So we did that in that way to try and provide that kind of high level overview, but on a case by case basis, or for what it means for any given local authority or person considering a transport scheme or whatever, it would really need specific assessments underneath it. And another thing we try to do here is set out problems. What problems do people have in their practice and in their day-to-day lives, if you like? So we carried out some Delphi exercise where we were asking people to rank different problems, the importance of them. An issue with that really is that most problems people consider important to address. There wasn't a lot of differentiation in terms of priority, but people saw most of the things out there as being priorities. There was some difference between groups of people. But what we did is try and set out problems in a whole series of network diagrams and then show what the potential solutions were. So some of the interventions in the report, you can see here that you don't need to be able to see the kind of resolution of it, but where they're dark green, they had a higher strength of evidence or higher level of effect, and the kind of solid lines were the ones that had higher strength of evidence. So what we were trying to do is to show for any given problem, people could just pick the problems that were relevant to their context, and then these diagrams would hopefully show them the solutions that existed for that problem and whether there was evidence that they worked and which ones of them had better evidence. I think for some of the kind of questions we have for the indoor-outdoor environment may be useful to take similar approaches to this. And then overall, it's going back to the fact that we may not always be interested in one particular pollutant or outcome, that in terms of improving health and protecting health, there's a whole range of things we're trying to consider at once. So in the rounds here, there's a question about how to deliver net benefits overall. So in some cases, we might be carrying out assessments and we're trying to account for these different determinants of health, the different outcomes linked to them. So it may be noise, it may be heat, it may be air pollution, there may be other aspects that we're trying to address, and it may inevitably lead to taking actions that have some negative consequences for some determinants, but positive ones for others. So how do we address that in our evaluations and our assessments and our conversations? I think there's an open question there. I certainly think that taking approaches which try and present things together rather than independently and start trying to look at the interconnectedness between things is a potentially helpful approach. I'll shy away from saying that I have the answer to what a net gain might mean or how it might be delivered in practice. I think it's a very complicated thing to get into, but I think it's a nice principle to aim for overall, that whilst there may be trade-offs and some things might go up or down, overall the intention should be really to try and account for all the factors that affect health and try and look at whether it can be improved in total. So that's a bit about my world. I've talked for maybe a bit too long about that. There's a whole range of environmental determinants of health and exposures that PHE works on. So I mentioned that a colleague will speak about radiological exposures in future. They've done work on assessing indoor exposures in radiological events. And a lot of the work that they've done around characterizing buildings and indoor and outdoor exchange, very relevant to chemicals, very relevant in general to exposures indoors. Another colleague will speak about noise and health in future. And I hope to get contributions as well from people involved in our Radon work and extreme events work and dedicated work on indoor air quality and health as well. So I hope that's been an interesting whistle-stop tour and given a bit of insight into the potentially, I suppose, different way that might conceptualize some of these issues and covered it from my day job, and I'll be happy to pick up questions.
Thanks, Jim, that was great. I have a question to start us off, and then if everyone else can put theirs in the chat box, I can see to them. But my first one was about the interventions and the influences of Public Health England from different sources of pollution. And you showed a schematic about halfway through your talk about the different sources of air pollution. You said a little bit about the domestic. I wondered if there were some sources that Public Health England had more influence over than others, and if you can comment on that.
Yeah. In terms of influence over sources, it's difficult to say that as an organisation we have a direct influence over sources per se, I guess, in that our role is more to present and summarise health evidence. So I suppose it's how to frame which sources are more or less important. And in terms of health evidence, the burden of health, proven burden of health for particulate air pollution is very high, and it's one of the main drivers in that outdoor context, which is partly what's sort of driving the focus on residential contributions and wood burning and so on from DEFRA. I think what makes a difference, I suppose, is some of the some of the emerging health evidence and some of the things coming through about links to neurological effects and the approaches that have been taken to consider exposures across the life course. So a part of it is that air pollution affects people's health from before birth until death, really, in that the reduction of lung capacity that can occur early on and some of the effects that can persist into later life. Putting that across sort of brings the focus, I think, around to what can be done to reduce people's exposure to air pollutants in general at different stages of life. And I think that's important to consider, that how do we reduce people's exposure to air pollution in general when they're young, when people are developing, as well as in adult life and onwards. And also, how do we account for vulnerable groups, for people that may have pre-existing cardiorespiratory ill health? How are they accounted for in these cases? So I think that's probably more where we're coming from with that. I guess is maybe partly addresses your question, Helen. I don't know if you want to follow that up.
Yeah, that's good, thanks. There's 3 questions now in the chat. Well, the first one's from Christina, and she's asking, what are the important species to trace for health exposures to fire? And the example you gave was tracked PM10.
Yeah, there's a reason for that. And it is that PM10 is almost always the main proxy for exposure to smoke in general that we get in fires. So we tend to have monitors that will look for gas species as well. But the data sometimes with those are inconsistent, and particulate matter, particularly fine particulate matter, is generally one of the best indicator species. And when we start looking at acute exposures in fires, become interested in people's exposure over 24, 48-hour rolling averages, the past and future exposure to particulate matter, because it acts as a proxy for everything else, but it's not the be-all and end-all in reality. That there's a whole range of combustion products, asphyxiants, and those that have toxic effects, as well as PM. So it may seem a bit strange to focus on particulate matter, because generally the focus on that is kind of longer term, but it's more that also represents all of the things that pose nasty acute hazard as well. You can get a lot more information on this if you Google toxicological profile of combustion products. There's a PhD report. The author was, I think, James Wakefield, and it sets out the profile of different combustion products in different types of fire. And there's a higher yield of the toxic components when fires are poorly ventilated and smoking, and they tend to be the problem as well because of the reduced buoyancy. You don't get such a lift off when it's not a hot fire.
One other question now from Alison, and she's asking, given the range of source types, do you think that our monitoring network gives us enough information about exposure in urban areas, since it was designed with mainly traffic and industrial sources in mind? Yeah,
I think inevitably I'm going to say that the more information that you have to build an exposure assessment on, the better. I guess we're focusing on the outdoor with this question, and it's because I've found in some instances it's becoming more common for people to present personal, like low-cost centre data sometimes in instance and say, what does it mean? That's coming up more often, and also this community monitoring networks supplement local authority ones. I certainly think there's work afoot nationally in terms of what's provided by the fixed term monitors and local authority air quality monitoring, but then that's always going to be linked to what their legislative roles are for local air quality. And we've got another question with all of this about characterising indoor environments as well, where sort of day to day, what information do people really have on which to base assessments? And my gut feeling with that is that some of it almost goes down to individual householders trying to characterise the sources by using checklists and things like that. You're not necessarily going to have the monitoring side of it, although that has its place as well.
Bit of a different question now from Darren Wolf, and that's about microplastics, and he's asking what Public Health England's view is on microplastics and surface water runoff and potential future solutions.
The honest answer is I don't know offhand. I'm not sure if colleagues in our toxicology team are working on that. Yeah, I would be speculating, so
okay.
I have to say I don't know.
And then the last question we've got is from Tom, and that's saying that you've emphasised the transient process for the exposure outdoor and indoor, where the latter is delayed compared to the former. But would you start to consider a cloud of concentration for these, or even a peak concentration for these?
Say again, Helen, the last part of the question.
It's in the chat box.
Oh, yeah, sorry.
Whether you'd consider a cloud of concentration for these exposures.
Yeah, okay. So when thinking about it, you kind of get into the toxicological side and dose response. So for some chemicals, the duration of exposure is as important as the concentration. And for others, the concentration is the driver for health effects. So in some cases, in acute releases, you're trying to basically minimize the toxic loads that people are exposed to, so it doesn't hit toxic load limits. And often that's driven by peak concentration in those circumstances. But if you start considering other health endpoints and other chemicals and longer term exposures, then it's more the kind of averaged out exposure over time that becomes important. So it varies depending on the health outcomes and endpoints that you're focused on and the context. So I think when I kind of think about this in terms of outdoor and indoor air quality, and going back to particulate matter, that you could apply some standards based on thresholds to exposure to particulates in emergency or acute settings that would be very much higher than the longer term exposure levels that you might consider acceptable, because you switch from trying to prevent immediate short-term effects to trying to minimize long-term effects, and the health outcomes linked with each are different.
We've now got a question from Janet, and this might be our last one in the interest of time, but she's saying that you mentioned that outdoor monitoring networks are tied to legislation and responsibilities of local authorities. But for indoor pollution is more legislation needed, and who is responsible? Will that change in legislation drive monitoring or knowledge requirements?
Yeah, it's an interesting question. Yeah, I'd be interested in the views of our air quality and public health team on this. I suppose my kind of thinking it through, that in terms of outdoor monitoring networks and local authority air quality management is quite established in legislation, but then in indoor context, of people spending 90% of their time indoors, and a high proportion of that is really domestic. And then how do you legislate for monitoring of domestic exposures? I kind of think in workplace settings, you've got, I mean, you could go back to things like HSE occupational exposure standards, that there's a duty of care on businesses to ensure that their employees aren't exposed to chemicals above short and long-term workplace limits. So I suppose that kind of thing's there in work settings. But then if you start thinking about office and other environments, that it's not comparable really to industrial contexts. And I think that's where that question is there an employer's responsibility there? Yeah, I think, I mean, it would be one way of kind of pursuing better exposure data, I suppose. But I don't know.
Alison's added to that just by asking about public spaces like railway stations, and I guess shopping centres and things like that as well. Another one.
Yeah.
Yeah.
Yes, yeah, Birmingham New Street. Yeah, that's it's an interesting. Yeah, I mean, it is interesting, because it ultimately comes down to the ideal world where you really want people to have that personal connection to exposures to be able to minimise them. But what would an ideal look like? You would always have some sense of your exposure to pollutants. So would you carry a personal monitor at all times, and you'd be constantly looking at it? But it kind of goes back to the point at the end of this presentation, that even if you did so, that your worldview is going to be influenced by whatever numbers on that monitor, and whatever numbers on that monitor might be 1 or 2 pollutants that you've chosen. But how well does that represent all the other environmental determinants of health that might be affecting you at that moment? Whether that's heat stress or noise or other things that you, by kind of picking 1 or 2 at a time, it would almost be great to have a personal monitor that just measured everything, and you got a kind of summary of everything, and you permanently balancing your risks. I think that would be the kind of ideal. But yeah, how do you interpret that if you had it? I don't know. But yeah, I know I'm starting to waffle now, but I think generally providing information to people, the more information that you have, the better you're able to make an informed decision.
Well, thanks very much, Jim, for sharing that with us today and for taking the time to make that talk. I've shared in the chat box details of our future seminar talks, and that's on our website, and I'll also be tweeting them over the next few weeks. But we're basically going to be sharing talks every other week, every other Tuesday, until July time at the moment, and then we'll have a pause over the summer and start again in autumn, probably October. But for now, if anyone else has got any further questions for Jim, feel free to email the Breathing City email address that I shared at the start, or tweet us. And if that's all for today, then we can wrap up, and I'll see you all in 2 weeks, hopefully.